Good morning, everybody. Good morning, Rita. We're so glad you're here. Thank you for joining us.
Good morning.
Okay. Good morning, everybody. We will get started in just a couple minutes. We'll give everyone a little grace period here to get settled, and then we will kick it off. Maybe just about 1 or 2 more minutes. But in the meantime, for those of you who are on these calls multiple times a month with us, you know the drill. Can you please put your name and your organization in the chat box for us for our attendance tracking? Helps us stay organized. And we will be having a nice discussion today. So if you have questions that you're thinking of throughout the discussion, you can go ahead and put them in the chat and we will moderate those for you, or you are welcome to take yourself off mute and ask when we get to the Q&A section. Are people hearing me okay?
Yes.
Yes, okay, great. Yes. Oh, thanks, Katie. Okay. It's like, uh-oh, I just gave my spiel and nothing's coming through. So, okay.
They're just ignoring you.
Yeah, that's okay. I'm sure everybody is really tired of hearing me say it. It's okay. Thanks, everybody. Wonderful. So good to see you all. Okay, I think we can go ahead and get going. Taryn, if you wouldn't mind advancing the slides. Wonderful. So welcome. Good morning, everybody, to our June ISP call. We today have a wonderfully exciting special guest joining us. We're going to just do a really quick high-level recap of the ISP milestones and also introduce to you some of the changes that are coming down the pipe. And then we're going to have a conversation with Dr. Rita Lee around diversity, equity, and inclusion, and how those sync up with some of the new milestones that are coming. So we're really fortunate to have her and looking forward to that chat in just a little bit. But prior to that, I'm going to pass to Stephanie to just give us a quick walkthrough. Taryn, if you wouldn't mind advancing the slides. Great. I will pass to Steph for just our high-level reminders and updates.
Good morning, everybody. Thanks for taking the time to be with us this morning. So these 10 building blocks, especially for those of you that have been with us all the way through SIM up to now, are pretty familiar. So we have tried to tie all of our work in practice innovation back to the Bodenheimer building blocks and try to give ourselves some kind of, infrastructure foundation to follow across multiple programs. So as we began to think about how we can be more intentional about including milestones for practices and ourselves as facilitators to be really, really just explicitly concentrated on these as milestones for practices, we tried to tie them back to these 10 to these 10 building blocks. I think, Kathy, are they on the next slide?
Yes, they are.
Taryn?
Sorry, I was
Sorry,
mute.
I guess Taryn's driving.
Yeah.
We're gonna come, these are the optional building blocks that we created kind of as we were evolving as a program, as we became increasingly aware of the need to be, again, explicit about milestones to address social needs and substance use disorder. We introduced the telehealth milestones as we were trying to support practices in early times of COVID to pivot from seeing patients in person to using telehealth technology to support their work with patients. So we have really tried to be aware of what practices need when they need it and try to create some infrastructure to support that through ISP. We're lucky, and I know I'm getting long-winded, but we're lucky with ISP that we have a funder that allows us to do that, that we don't have to be real rigid in everything that we're doing over the course of implementing this project. So I think that makes it fun. It sometimes can make it a little bit of a moving target, but I think it's good that we are able to respond to what's happening in the world. So Taryn, I think the next one, yes. So these are the new inclusivity and equity milestones. So you'll remember last year, the Practice Innovation Program made a statement about our intention to really work on how we move in the space of diversity, equity, and inclusion as a program. And one of the steps that we're taking is to create these milestones. Rita has been incredibly instrumental, and her team in helping us craft language around these milestones so that you as a facilitator and the practices that you're supporting can have some really concrete things to do that will hopefully elevate this work in the community. Rita's going to talk more about this as we introduce her. I want to be completely transparent that I'm in new space and territory with this work too. And so this has been a real learning opportunity for me to kind of think about how do you translate, kind of academic ideas or information that I might read in a book that's recommended to me into something that we can actually do on the ground to hopefully encourage change. So I know I don't describe this as eloquently as many other people do, but that's kind of where I'm sitting with this right now. So I'm not going to read all of these to you. They'll be available to you in the new MAC in July. You'll see them. We're not going to just throw them into the MAC and hope for the best. We're going to continue to touch base with you. We'll have the support of Rita and her team to continue to bring education, bring information, have a sounding board for you as you start to work with practices in this realm as part of ISP. So this is just sort of our dip the toe in day. I wanted you to see them so that you're not surprised when you see them in the assessment with the practices that opens in July. Not all of you will be doing a MAC in July, so I hope that didn't raise everyone's heart rates. It's for the new practices that are joining us then. And then anytime after that point, you'll see these as an inclusion as part of that assessment. Did I miss anything, team?
No.
All right, I'm going to distribute it so that we have as much time as possible for Rita to be with our team today.
Wonderful. So, as Steph said, Rita has been working with the team to go through these milestones, but she has such a lovely bio, and I hope you will indulge me and let me read it to the group, Rita, because you are wonderful. Rita Lee is a professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. She has a passion for medical education, leadership, development, and advocacy. She's the Director of Health System Science and Health Equity Education for the School of Medicine, and the Director of Health Equity Education and Training for the Anschutz Medical Campus. She's a core faculty for the ACL GIM LEAD program, which is a faculty leadership development program. She serves on the National LGBTQIA+ Health Education Center Advisory Board. She's one of the founding members of the UC Health Integrated Transgender Program, which is a multidisciplinary clinical program to provide gender-affirming care to individuals with gender incongruence. Welcome, Rita. Thank you so much for being here today.
Great. Well, thank you so much. Thank you all for being here. I'm really excited to kind of begin this journey with you. And I'm just gonna start by saying that, I think the purpose of today's conversation is really to kind of give you a high level overview of some of the framework with what we are hoping to be working with, but knowing that this is just the beginning of the journey, and we're really here, to kind of set like a foundation for what we're going to be doing, but also, recognize that we're here also to support you through this work and to provide any additional education, training, insights that you all feel like you need. And part of it is, I don't know where everybody is starting from. And so we'll start in the same place, and then we'll figure out what direction we need to move together. Does that work? Okay. And I am a very casual kind of presenter, so feel free to unmute and interrupt. I lost my chat box somewhere, so if there's something that shows up in the chat, I'll maybe ask Kathy or Stephanie to.
I'll catch those for you, Rita, no problem.
Perfect, thank you. All right, so I think we all recognize that, there's been a lot of conversation around differences in health outcomes, right? And a lot of the current milestones in terms of looking at practice improvement, a lot of people are saying, do we have diabetes control? Do we have high blood pressure control? And when we look at the practice levels at the whole, right, we know that there are gaps in terms of where we want to be. But what we don't always recognize is that those gaps might be different depending on what populations we're looking at. I could give days long, talks on health disparities by population A, B, C, D, you name the demographic, and we can kind of talk about health disparities. I'm not going to spend a ton of time on that, but just highlighting that, when we look, this is just some hypertension data that's out there. But so if you have like an overall practice of hypertension control, or diagnosis that's hovering at like 40%, the problem is right, that might be inadvertently missing some people or some certain subpopulations that might have increased prevalence of hypertension or poor control, right? So this is just one demonstration of the light blue is non-Hispanic white individuals versus non-Hispanic Black versus individuals who identify as Mexican American, other races or ethnicities, and then kind of the overall rate. And when you look at this overall rate, you're not necessarily seeing those differences where we can see in this one data set, right, that non-Hispanic Blacks have higher rates of being treatment eligible, they have lower rates of actually being treated, and higher levels of having their unmet goals among the treated, right? They're not getting to target. Right. And so if we're only looking at the overall levels, what we're doing is we're missing some of these differences that might be, number one, driving that data, and an opportunity to potentially say, hey, what's going on here? Okay. This is data from One Colorado. This is their report from 2014 on Transparent. It's on transgender health. And so they surveyed over 400 Coloradans Colorado adults who identified as transgender or non-binary. And they compared it to the behavioral risk factor surveillance survey. So it's a general Colorado population. And you can see that rates of mental health challenges like current depression, anxiety were astronomically high compared to the general population. And when you look at suicidality in this population, right, 36% reported that they had contemplated suicide in the past year compared to 4% of the general population. And 10% had actually attempted suicide in the last year. And we know that these differences exist across multiple subgroups of populations, right? And the question is right, there's a difference between difference and a disparity, right? Some difference is based on clinical appropriateness and patient need preferences, right? We would call that patient-centered care or family-centered care, and that is desirable difference. Okay, right? The last thing we want to do is force a patient to do something that they don't want to do. But this big part of this difference is really in how the healthcare systems operate, kind of what are the social structures that we live in terms of the legal and regulatory climate, as well as discrimination, biases, and stereotyping. And this is disparity, which is an undesired difference in health outcomes. And classically, the comparison is between the majority and the minoritized population, depending on what identity we're looking at, okay? And this came really, highlighted by the Institute of Medicine, which is now the National Academies, called Unequal Treatment. This was highlighted in 2003, looking at racial and ethnic disparities in healthcare. And as we have moved forward, we also recognize there are other dimensions of diversity that are also experiencing health disparities, which is that unwanted difference in health outcomes, right? Whether it's LGBTQI, people living with disabilities, and other intersections of identity, right? And I think, what is hard sometimes for us to see in our practices is that our systems and structures, so these individuals are all the same height, okay? Supposedly the baseball game is kind of, I don't watch sports, but this is the graphic that is always out there of people. This is like the holy grail of achieving their goals, which apparently is watching a baseball game. Not my goal personally, but anyway. But recognizing that like the systems and the structures are set against people, right? So this individual is on higher ground than this individual. And the fence is actually higher for this person over here. And when we think about equality, right, in practices and our practice environments, that's giving everybody the same box, but recognizing that, yeah, maybe we get this person over so they can see the game. This person maybe can eke out something if they're tiptoeing. But really this person, if you're giving them the same thing, they're still not going to have what they need to be successful. In our case, obviously, we're caring about health and well-being, right? But when we're thinking about equity, really what we're talking about is giving people what they need, okay? I add this, wheelchair graphic because, again, when we think about boxes, this is not equitable for somebody who might need an a mobility device like a walker, a wheelchair, or a scooter to access what it is that they need. And this is really kind of the lens that we created those milestones with, is to say, are we as a practice meeting the needs of our populations who have different structural challenges that they are facing both within our practice as well as external, those determinants of health. Okay. And the other thing is that we all need to recognize is that diversity, equity, inclusion is really a structural issue. I think when we often talk about this topic, we think that, we talk about like, quote unquote, the bad apple, like there's one person who's wearing, the KKK outfit, and that is the person who is the bad person that is perpetuating this. And yes, there are rare instances where that is that individual who still has explicit bias. But the vast majority of us really are these, we are good apples. We have the intentionality of being equitable and being fair to our patients and creating practices that are good, right? But we also have to recognize that there are those structural pieces, right? The ground is not level. The fence is not the same level for everybody. There are environmental issues that are underlying kind of the pieces that impact our patients' health, right? Literally air quality, right? If we're looking at this example, the soil that they are living in, what are their opportunities to succeed and grow as the apple orchard, right? We're all growing within that environment. And so what we use to think about this and break it down into kind of bite-sized pieces is the socioecologic model, right? Recognizing, yes, individual behaviors, whether it's the providers that are involved in the practice or their support staff or you all, right? We all have a role, but we live in interpersonal environments. So those are our relationships with other people. What are the patient relationships with their providers, their family members, their friends? And then there's also thinking about the community level for our patients as well as our practices. What is the social capital, right? When we think about that milestone around kind of the teaming piece of it, like who has the social capital, you know, in a typical hierarchic practice structure, right? What are the networks? What opportunities do they have to grow and expand? And then also the structural and societal factors like the laws and policies. So at the practice level, what is the late policy? Does that potentially create inequity for individuals who might be having trouble with transportation, for example, or childcare? What is the physical environment in terms of accessibility? In LGBT health, we also think about what do the bathrooms look like, you know, especially for our gender non-binary and transgender patients. What is the resource availability and the organization system? So that's like transportation. Where are the practices located? How are people accessing their ability to get care or access to the needs that they have? And so we offer that as a framework as we're thinking about implementing kind of some of these milestones to think about the different levels to consider as practices are saying, hey, do we have this? Are we able to achieve this? And so that's like the high level overview. I really wanted to make sure that we save a lot of time for kind of a discussion and questions about how is it that we're going to think about applying things. What information do you know? What questions do you have? And with that, let me find my stop share button on one of my 10 screens. And I'll open it up for dialogue.
Well, I'm always accused of not being comfortable with silence. so I'll try to prompt my friends that I see here with us this morning. I guess maybe, well, Rita, you can pull me back here if you want me to, but I always think about how can I take what I learn from people like Rita and move it into action. And maybe I do that too quickly. Like maybe that's not a good idea. But when I think about how can what we do as the practice innovation program and what we're trying to do as ISP, like make a dent in some of those figures that Rita's showing me. And so that's sort of like my academic approach to thinking about how do we do this? Which brings me back to us as a team. I mean, what are you experiencing right now as a facilitator from just your role as you react to what you're hearing from Rita this morning, or seeing maybe the approach we're taking with the milestones from the role that you see, because we know that you move you move around a lot more than we do from place to place.
All right, I'm going to speak up. So sorry, thanks, Steph, for prompting that. You know, this is not, it's something that I've been just really immersing myself in and doing a lot of research on, just trying to understand it myself as far as the differences in equities and just how to be able to do it. And so I appreciate Rita's like tangible, you know, takeaways, look at the appointment policies and things like that, just because it's hard for me to wrap my mind around, you know, what can we do differently? You know, I live in a very small rural town that is not very diverse in any way, shape, or form. And the practices that I used to work in here pretty much had this, you know, Latinx population and white population, essentially. So, you know, this is all very new for me. And so I appreciate the extra support that you guys are providing us and the education as we start navigating through this, because I really feel like it's something that I certainly will need on my end. So as far as practices go, you know, there's a couple I work with that are very focused on this and they're still trying to figure out what that looks like. But there are also several who they may be having the discussions internally, but it's not something that it seems like they're overly comfortable talking about in front of people that are outside of their immediate organization. So.
Yeah, I really appreciate you saying that. I mean, I think, you know, when we first delve into this content, it's really uncomfortable. And I think it's critically important to acknowledge, yeah, that like, and where's that zone of pushing into the uncomfortable where we are going to make some progress for ourselves and our practices, you know, and then, you know, you don't want to push too far over into that kind of danger zone where people kind of start shutting down, and everybody has a different range of where that's going to be. And the question is how do we move that dialogue forward? And what tools do you feel like you might need to kind of engage in that conversation?
Right, and I think that that's a big part for me, is that just the educating myself on it, so that when I bring it to the table, I'm very confident in bridging that. And you know, once you can do that, you can kind of assess, like, are they open to this discussion, or do we need to kind of take a step back and kind of enter a little more slowly. So I think step one, as far as I'm concerned, is getting the facilitators, I think, in a place where, you know, tips and techniques for being able to kind of slowly broach that subject for these practices that are a little more hesitant to do it. But also, again, the tangible takeaways of, you know, here's what we could actually do to kind of start addressing the inequities in your practice specifically.
Something that we've started talking about a little bit recently, well, this is more of like a bigger conversation we're having, and you know, we're a nonprofit, so we apply for funding, and it seems like a lot of grantors are shifting their funding priorities to social determinants of health and health equity, and that area, which is great. But we work for a rural facing organization, so that conversation of like, is rural a population that fits into that category, because we see a lot of disparities in rural Colorado, and like living in a rural area was a significant determinant for getting the COVID vaccine, say, but historically not really a marginalized population. So we're kind of trying to navigate those conversations now, which I think is interesting, and yeah, kind of a larger discussion. But I think like it is really encouraging now that a lot of our practices, and maybe it's just because we're talking about it more, I think we are looking more at the breakdown of demographics within practices. And I think that next piece, like at least where a lot of the practice I work with are at, is really being able to take that data and break demographics down by health outcome and really start to focus on what are some solutions that would improve outcomes for certain populations. And we do have some clinics that are like working with specific multicultural outreach companies and multilingual companies. So I feel like there is some movement, but it really depends on what practice. I don't even think some of the practices are having the conversation yet. So just some thoughts.
Yeah, thank you for sharing that. I think it's great that some of them are actually starting to look at the demographics. I think for a lot of practices, they're not even collecting the data, right? Sometimes that's the hardest place to start, is getting them even thinking about whether they want to do this and collecting data and figuring out how to do that.
Hi, this is Andrew. One of the things I focus on a lot are clinical quality measures. And I know your first slide, there's a lot of great information, but a lot of the practices, the coaches work with their small practices with EHRs where they can't pull out a quality measure and then look at it by race and ethnicity. Where do you suggest kind of starting on something like blood pressure and trying to identify, do you look at state level numbers and say maybe kind of your practice isn't going to align somewhat like this in this fashion, or, you know, until the HRs kind of catch up, they're not going to have that practice level data without a lot of like manual pulling of data and sorting it and again, like plugging different tables together, et cetera. So just any thoughts in terms of that?
I mean, you can look at state and national data. I mean, we know that those disparities are there. The challenge is that it's much harder to actually truly be actionable because it's not practice level data. You know, and one way is to maybe focus on kind of the smaller chunk of like, what are the, for say we're using hypertension as the example, is really focusing on those with like poorly controlled hypertension, right? They have the buckets of well-controlled, kind of that, you know, stage 1. Maybe those are, you know, what are the highest priority groups, and focusing on that. I don't know if they do, you know, different, if they're using like the complexity ratings, like HC scores, that type of thing, and looking, are there disparities there? You know, so it's just a smaller population for the manual poll.
Right, and then you can tie it back to the actual patient. Yeah, that makes a lot of sense. Thanks.
Yeah. You know, and then just the practical application when we think about like the socioecologic model of, you know, we'll use hypertension as an example because it's you know, QI for a lot of practices. But so, right at the interpersonal level, is there something about how we're communicating with different populations about whether their blood pressure really is in control or out of control? Like there's so much data about provider patient communication and rapport in terms of patients following through with their plan, right? Are they taking their prescriptions, their medications as prescribed? Are we adapting their prescription, you know, to either like a generic formulary? I use the $4 formulary a lot because a lot of my patients are lower income. Or am I giving them the fanciest schmancy, you know, new medication that they're like, I can't spend $200 a month on this copay. This is ridiculous, right? When we look at those community factors, you know, like, are there norms for like the measurement of blood pressure? Is that standardized across the practice? When we look at, are there support networks or educational supports for our patients? Are those accessed equitably? or is it like, if, I don't know, some places do like group visits, is it only certain population that's showing up for the group visits? Or, are the, nutrition counseling, is it culturally responsive? That type of thing. Does that make sense? Of like a practical way of trying to apply that model.
Yeah, that's really helpful.
Another thing that we're doing a series of equity trainings with a couple of practices that I'm working with for the Medical Legal Partnership implementation project. And one of the things that I'm learning about and noticing too is how much this impacts the teams in the practices, not just their patients. So trying to think about, and that was a place where I'm like, well, wow, as a practice facilitator working with a quality improvement team on a monthly basis that I've had a relationship with for years, like, how am I approaching these conversations? And is there something that's coming out that's shutting certain people down from being involved in conversations? And so that's one of the milestones that I was most interested in kind of teasing out, was how, as I'm trying to read it, that the practice implements team-based communication strategies to improve engagement of all team members. And I think practice facilitators were trained to think about that, but I'd always thought about it kind of more related to clinical hierarchy versus maybe other factors of why individuals do or don't participate or do not feel comfortable. And so that was one that I feel like, really I could be more aware when I'm doing the role of practice facilitator in this work. And so you'll see that one when you open this up in July. But I thought it was an interesting kind of translation of this work to practice facilitation. And also just being aware that the environments that we work in are a huge part of this work as well. Like, it's not just about patients. A lot of us have experienced things in our own lives. And so being aware and sensitive to that as we're kind of just showing up with an assessment. Like, I want it to be more than that, but sometimes I know that's how practices feel. So it's just kind of another insight that I've been kind of thinking about.
I'm curious what you all think about that particular one. Maybe I'll call on Kristen. Sorry, you had a nod, that subtle language.
Yeah, I'm not actually a practice facilitator. I work with Stephanie at the university. So I'm curious to hear how other people are approaching it though, and thinking about it in their work.
I popped it into the chat so you can read it. I know that we sort of flew through the language of those new milestones, but this is one of them that would be an element of team-based care.
I think one thing as a practice facilitator and a person who is also really trying to work hard at looking at these things in ways that I haven't before and trying to be very mindful. I don't want to mess it up. Like, I don't want to make mistakes. And so I feel a little nervous sometimes about, am I saying the right thing? Am I going down the right path? Are we opening a can of worms? Are we being sensitive? So I feel like, though I feel courage and I'm getting out there and having some of these conversations, some of my internal fears prohibit me from helping guide those conversations a little bit. And I'm wondering if anybody else is feeling vulnerable enough to say that they have similar feelings or experiences, or maybe I'm just the outlier.
Every day of my life, I make mistakes. I am learning and growing. Every time I teach this, I learn from everybody else.
Yeah, I think, Kathy, that made me think of something that I've talked about a lot when it comes to like something like void in data, right? So like seeing what's what's not visible is such a challenge. And I think this is where something like this milestone comes into place, is that it's trying to recognize something that's a void for us. And if we're not in the clinic all the time, seeing those voids can be a really subtle experience. So I think what this, for the practices that I facilitate, not on this project, I think it makes me aware that, like you said, Kathy, that you want to be good at seeing things that you haven't seen before, but that's easier said than done when you're looking at a black hole, right? So I really hear what you're saying, and I think it's just going to take some time, some practice, some perspective from all of us.
Yeah. Thanks.
Yeah, Kathy, I put in the chat 100%. I mean, I feel that way too, and want to be an ally and a partner. And learning how to do that with grace is a learning curve. I think. And so what I'm hopeful for, and this may be naive, and Rita can just tell me if it is, from your perspective, but what I'm hopeful is that having the way my brain works, having the milestones there as sort of like a place to start, like a place to kind of just get some traction in the language that the practice facilitation brain works, kind of will give me the confidence, or help build confidence in how I move through this. It'll give me just, it's like, oh yeah, I recognize our work here. I recognize how we can translate here, and that will help, give me boost my courage.
Yeah, I think I'd like to think of the milestones as a reminder, to have it at the front of mind, right? And there might be different dimensions that will come over time. And, like Taryn was saying about kind of seeing that black hole, if you poke that little hole, you start to see a little light. And then as you see it, there's more holes that get poked into it, because again, it's that, like, once you start to see, you can start to see more, if that makes any sense. I mean, when I first started this work, my focus was on LGBT health. And as I started to do more LGBT health, I realized, like, the transgender population and people who identified as gender incongruent, like, that was a huge gap. And so I said, oh, I need to see this, quote unquote, more, right? And then as I started to work with that community, we started to recognize that there was more intersectionality, right? Like, trans women of color are getting murdered at much higher rates than white trans women. And so that brought me into that world, and I started to see that. And then we started to see different, more realms of disability, et cetera. And like I said, I'm seeing new things every single day. We don't expect you. I'm not perfect. We're never going to get there. This is like a lifelong journey. And I want to encourage all of you to not be afraid of taking that first step. And even when we think about, the milestone of the team-based communication, I think a lot of it is recognizing that structurally, yes, we have that hierarchy, but when you think about your practices, at least when I think about my practice, the vast majority of our staff and faculty that come from diverse backgrounds or marginalized populations, they're not the physicians, they're not the practice leadership. They're usually, our medical assistants and we call them PARs, but are like our front desk staff or phone staff, right? And offering them a voice and offering them the opportunity for advancement, so maybe they can become then like the nurses, and then maybe the nurses become the practitioner, the advanced practice providers, or maybe they often go to medical school, right? So part of it is like Stephanie was saying, is you have to start somewhere, right? And hopefully that kind of builds upon itself. Jennifer, you unmuted?
Yeah, and I was just going to say, I was having a conversation with my kids over the weekend about when we were kind of talking about this like equity work and inclusion work, and one of their friends has just graduated and is planning to go into social work. And you said it so perfectly, because I was like, I did not do a good job at explaining that to my kids over the weekend. But you said it so perfectly. You said giving people what they need. And I think that was such a like perfect way to say it, and such a perfect way even for us just to start this work. I think it's just like, give people what they need. So I'm going to go back and have this conversation with the kids again. It's my do-over, and it'll be better this time. But I think that was just such a good, I don't know, it's just such a good way to say it. Like, equity is giving people what they need.
Well, Stephanie, it's BJ. Can you guys hear me? You knew I couldn't stay on mute for too long.
Well, I wasn't going to call on you. I felt bad, but you're always my go-to.
Yeah, well, I was running late, so I had to kind of catch up a little bit, and I didn't want to like really look stupid in front of my peers. So everything really that everyone has mentioned really resonates with me so far in the discussion. And, you know, I've really sort of always had a love-hate relationship with the milestones document for lots of different reasons that we don't have time to go into. But I think that the really super valuable thing for me that I've come to realize that the milestones does is, number one, it's a great way for the clinic to step on the scales. I mean, I hate stepping on the scales, obviously, but I also recognize the value of that and the need. So I think, but it's too narrow just stepping on the scales, because it also gives you a lens to look at what could be. You know, it's all about prioritization and about meeting practices where they are. And I've certainly learned over the years that it's not a linear process. But I think that when you have those conversations, and the milestone document is a great place to start, it begins to shine light on lots of different areas and the whole spectrum of what's possible in terms of practice transformation. And I love, although I was late, Rita, so I missed the whole, you know, giving people what they need thing, but I think it also is helping people find their voice and helping people realize what they need. So I think that that's one thing. And it's interesting, Steph, that you were talking so much about the team-based care, because for my ISP practices, and part of it is I'm kind of pushing them in this direction, but I'm having them look at staff turnover rate and what I call the love, joy, and job satisfaction factor in their practice, and tying that back to the whole team-based care piece. And it does start with that group, and within the group, with the care team, it starts with the individual and realizing where you are with all of this in terms of your biases, your skills and comfort with conflict, with communication, with just a zillion different things. And so when you look at all those moving parts, sometimes it gets to be a little bit overwhelming. So I'm trying to get folks to at least begin the conversation through the milestones, and then look at where are you, what's your stuff, what your beliefs are. And again, they may be implicit. I mean, that how do those impact your relationships within your team and the functioning within your team, as well as they impact what you do with your patients and how you react with your patients.
I think those are fantastic points. The thing that I personally, so, you know, I obviously love the socioecologic model because I love the socioecologic model. I wouldn't have presented it otherwise. But I think the great thing about that is it can break down something that feels so overwhelming into bite-sized pieces. And we're not saying that you as the practice transformation, the practice facilitation coach or the practice has to do everything. Like, right, I think we all have a little bit of pieces into solving like structural racism and oppression. I get that we have our pieces in our day-to-day lives, but you alone as one individual or one practice, we're not going to solve the whole thing. But if we are each picking something that makes sense for our practice and chiseling away at it, one small step at a time, then we will collectively, right, as the larger group, make progress. And so it's not pick all the levels, it's pick the one level that you feel like you have, or the practice feels like they have control over or wants to tackle, right? So even like, one of the milestones is on collecting patient demographics. A lot of them will, a lot of practices will collect maybe like socioeconomic data, maybe they'll collect self-identified race, but a lot of them don't. In our world, and again, in my world, focusing on LGBTQ health, we don't it's not a routine thing that we collect an individual's gender identity or their sexual orientation. And that is something that we had to actually build into our system. And it's, it's a slow on-ramp to get people to actually, we have now a place to hold it in our electronic health record, but then getting people to ask is like the next step, right? And moving in and out with that comfort level. And again, we're not solving everything at one time, but we're trying to break it down into little pieces that feel more bite-sized for you all or for your practices.
Yeah, and we're in the process. I mean, BJ, you know me, and we know one another's love-hate relationships with all of these things. We're writing an implementation guide. So in that, we'll be able to break it down. Listening to Rita talking about these bite-sized pieces, we're trying to create like what do we mean? Like, what are the things that the practice can actually do? What are the action items so that you could say, yeah, we are actually addressing this. It's not going to be ready by July 1st. Well, maybe it will. It'll be ready by July 19th when we meet again. And that's my goal, is to have it for the next time that the learning community is together. But yeah, so Rita's question here about what questions do you need answered in the implementation guide? And I know you're just seeing some of these for the first time, but if you have thoughts about that today, and I also want to say that I think the implementation guide can be organic. Like, we don't have to just publish it and say it shall be. As we go, we can add to it, and learning from what you're doing, as you're putting these out into the world, we can keep adding those action items or, just suggestions about ways to address some of this that's working for you all. But does anybody have anything in terms of today about questions that you'd like addressed or answered in the implementation guide? Like, how in the world do we do this? It may just be too early. I'm trying to get to the draft right now, but we'll share this with you once we have a good, strong starting point for your reactions and suggestions and how we can use it. I know we're getting close to the top of the hour. Would it be helpful if I circulate this draft, or that's not a draft. These are the new inclusivity and equity milestones to you all before the MAC opens. So then you won't see them for the first time when you're sitting down with a practice. I think I'm answering my own question, but I'm just going to follow BJ's nodding head. I'm going to send them to you. So then you'll at least see them. There's 9 of them. It's not a huge number. And we've placed them in the MAC so that, when you do open it and split up at the top, it'll be the first thing that practices address. For those of you that are, completing this with practices in July, I'd encourage you to take that or leave that in terms of when you introduce them. If it doesn't feel easy to put them to open with that, you can do the rest of the MAC first and come back to it. You'll see we're adding them also to the Excel spreadsheet that we use, that I think Katie created for us way back when, to be able to look at the milestones all together outside of Split. So we're going to add them there, but I want you to feel like you're empowered to use them in a way that seems right at each practice. And they are, I mean, we want you to answer, we want the practices to submit a score, but you don't have to follow that particular format with practices as you're doing this with them for the first time.
And I'm curious if you would all be willing to indulge me and put in the chat like one sentence or a few words about kind of how you're feeling about this work right now. Maybe that'll help us kind of design the implementation guide. And it's okay if the word is terrified. BJ, do you mind if I ask which part feels overwhelming? Or the whole thing?
I think it's more the whole issue of competing priorities. And with everything that all the practices that I work with are going through at the moment, it's like what space, and maybe I'm being a control freak. This is not an insight into my persona at all. Because it's really up to the practices to decide what their priorities are. Sometimes I get a little bit protective of them just because they're in such a vulnerable spot right now, juggling so many different things, that sometimes I feel guilty when I shine that light on one more thing to consider. So that's where the overwhelmed is looking at this in the whole mix of everything.
I hear ya. It does feel overwhelming to feel like we're adding on. I guess potentially a different lens would be, you know, if they notice that there are differences. So you missed the first slide. We saw like disparities in like hypertension control. I just showed one paper that had the graphic, like the overall hypertension control rate was like 47%, but in the non-Hispanic Black population, the rates of not being controlled were something like 60%. So it was much higher. And so it was actually skewing that demographic up. Of the flip side of it is if you look at the demographics and you can say, hey, there's a population that is you know, there's inequity in, you know, hypertension control in a particular population. Could you say like, you know, let's target that population and what those particular needs are. And maybe the overall metrics will get better if you're being a little bit more focused in the populations that need more assistance, if that makes sense. Great. Anybody else have any thoughts or feelings? All right. Feel free to reach out to me. I'm easy to reach. I'm rita.lee@cuanschutz.edu, or, you know, Kathy or Stephanie, for what other training or information you feel like you need. And I think as you look at it and move forward, I imagine you'll have more questions that will come up. And as you know, as you talk to your practices, they'll be like, oh my God, I need this, I can't do this, or whatever. We are here to be supportive, not, you know, our goal is to move this needle forward and not to be punitive or judgmental or anything. We're all a work in progress. So, thank you all for letting me waste your time.
Oh, Rita,
Thank you. That was great.